have given you all of my heart, but there's someone who has torn it apart, and she's taken just all that I have. If you wanna try to love again, well baby, I'll try to love again, but I know the first cut is the deepest. Well baby, I know the first cut is the deepest.
We're ready to start again. Did everybody get a handout on the Braden scale? If not, raise your hand and Joe will give you one. Okay, great. This wound seminar takes a lot of planning, and it took several months in advance to do this. So I would like to recognize the planning committee members. Without it being possible with them, well, it would have been possible without them. I'd like to recognize Mark Johnson. He's from the South Texas Geriatric Education Center and UT Health Science Center, and he's our web media specialist, and he's recording this seminar for us. And if you would like to purchase a DVD afterwards, they're $5 for each day and $10 for both days. So we have a form out there where registration is, and just fill out that form, and we can get this DVD out to you. I also like to recognize Pat Walters. She's not here today, she's over at Audi, but she's been very instrumental in planning this program. Our next program planner is Cherie Love, and she's one of our speakers. She's right here. And our next person is Joe Zapata, and he's from South Texas Geriatric Education Center. He's there in the rear. Just raise your hand. There he is. Okay, great. And then, of course, Diane Rudolph, our pretty speaker. She's very wonderful, and she's sitting right here in the front. I'd like to introduce our next speaker. Cherie Love has worked for the VA for the past 17 years as an RN. She started out as a student nurse technician here, and then LVN, and then RN. No? Not LVN, okay, sorry. Just as a student nurse technician, and then RN. She has worked in the areas of ICU, surgery, PACU, telemetry, and she presently works in acute long-term care here at KTC 2A. She became wound care certified last November and got her CWCN. She did her wound care training at Eastern Kansas VA Wound Academy in Leavenworth, Kansas, and so we're very proud of her. And let's give a warm welcome to Cherie.
Good morning. Good morning. I'm going to be talking to y'all about pressure ulcers. I know Diane spoke about it, but we're going to go a little more in depth on this. We're going to look at identify causes of pressure ulcers, identify common locations where they're developed, going to go through the stages again, and then some treatment modalities. We want to, it's especially important in today's hospital environment that we have a evidence-based best practice ulcer prevention program, and we're going to talk about what that would entail. We want to be able to effectively and competently use a Braden scale. That's what the VA, I know some of y'all are from facilities outside the VA, but that's what the VA uses, and so that's the one we're going to look at today. And we want to be able to accurately assess and document pressure ulcers across the healing process. The problem with pressure ulcers is international in scope. We have the National Pressure Ulcer Advisory Panel, and then there's the European Pressure Ulcer Advisory Panel. So this is not just a problem in the United States, it's worldwide. And it is addressed in the Healthy People 2020. One of the goals is to reduce the incidence of pressure ulcers in long-term care. And also, it's a Joint Commission National Patient Safety Goal. Pressure ulcers present a very significant threat to especially our geriatric population, where they have decreased mobility, where they have decreased nutritional problems, sensory deficits, all those type of things. So, and it can be seen in any hospital setting, from the ER all the way through to long-term care. I don't know if any of y'all have worked ER, but a lot of times you might have a patient that is on the gurney for a long period of time, and that's why it's so important when they get to the unit that you assess their skin, because in the time period that they've been laying on that gurney in ER, they could have developed a pressure ulcer. So one of the things that Joint Commission also is saying that each facility needs to have a written plan for identifying the risk for and a written plan for preventing pressure ulcers. Part of that plan should include an assessment at the time of admission so that you can identify residents that would be at risk for pressure ulcers or ones that already have an area of pressure problem upon admittance. And that's why when Diane was talking about assessments, it's so important that people look at and document appropriately the location, the problem, etc. So, Medicare and Medicaid and insurance companies are following. They will not provide reimbursement for pressure ulcers that develop during a hospital stay or a residential stay. As I've mentioned, is part of practice regulations that we have a process in place to assess, identify people at risk, and to prevent it. And then there's a big thing that happens, and it's litigation. If a patient under your watch develops a pressure ulcer that was considered an avoidable pressure ulcer, you may be subject to litigation. So just what is a pressure ulcer? The National Pressure Ulcer Advisory Panel defines it as a localized injury to the skin or the underlying tissue, usually over a bony prominence, as a result of pressure or pressure in combination with shear and friction. Pressure ulcers develop when the capillaries supplying the skin and subcutaneous tissue are compressed enough that it impedes the flow of the blood nutrients to the tissue, and it causes necrosis. For each individual, that pressure, that capillary closing pressure is different. It can range from 20 millimeters of mercury to 40 millimeters of mercury. 32 is considered the average. So that's what, when we talk about offloading pressure, we want to reduce the pressure interface between the tissue and the surface. Pressure ulcers are usually caused by prolonged and unrelieved pressure, but it doesn't have to be. It can occur in as short as 1 to 2 hours. And they usually occur over bony prominences, but they can occur other places. And they can develop from the use of a medical device. How many of y'all have had patients on oxygen that their ears develop ulcers? That's a pressure ulcer. How many of you have had patients that have glasses that don't fit well and they get pressure ulcers on the bridge of their nose? Those are pressure ulcers. But not all ulcers are pressure ulcers. Just as a zebra and a unicorn and a pony are not a horse, a venous ulcer, an arterial ulcer, or the incontinence-associated dermatitis, those are not pressure ulcers. So when you, it's like Diane was saying, when you identify something in the chart as a pressure ulcer, you want to make sure it really is a pressure ulcer and that you're not misidentifying the cause. The common pressure sites. How many of you have patients in wheelchairs that stay in wheelchairs most of the time that are prone to ulcers? Where do you see those ulcers develop on people in wheelchairs? On their issues is the common place, but they can also develop on their feet from the footrest, especially if the wheelchair may not be in the best of repair. That's why you want to make sure that your equipment is good. And there are cushions and stuff for wheelchairs that will offload the pressure to those areas. On the back, you're looking at the back of the head, the scapula, the spine, especially if you have a patient that has a kyphotic back. They will break down on their spine very quickly. The sacrum, the trochanters, the ischial tuberosities, the heels, and the feet. And then if they lay on their side, you have the elbows, the shoulder, the ears, and anywhere along their extremities. Okay, is this a pressure ulcer? Now think about it. Look at the shape of that. It's a bedpan. It's a medical device. A patient was left on a bedpan too long, prolonged unrelieved pressure, and it developed a pressure ulcer. Diane went over the stages with you. There are the suspected deep tissue injury, the stage 1, stage 2, stage 3, stage 4, and then stageable. The suspected deep tissue injury is usually purple or maroon, localized to a certain area. It could be a blood-filled blister due to damage of the underlying tissue. It may be painful, it may be tender. It may either be indurated or hard, or it could be boggy. It may be cooler than the adjacent tissue or warmer. In a suspected deep tissue injury, it's most likely going to evolve even with treatment. So where do you think you would see suspected deep tissue injuries most? Yeah. Okay. We all know that we have specialty items for bariatric patients. But we may not have specialty beds and stuff readily available for our above average in height patients. Have you walked into a room and seen a tall person over 6 foot that rests their heel on the footboard of the bed? Yeah. The reason I bring this up, we've had 2 cases just in the last year of a patient that was too long for the bed and rested their heels on the foot of the bed and developed a pressure ulcer. And both of them started out with a suspected deep tissue injury. So you have to be vigilant. Everybody has to watch. If you walk in a room and you see that happening, either you need to get a bed that's appropriate for the patient or find some way to relieve that pressure. You know, reminding them, don't rest your heels on that footboard. When it occurs, you don't know how deep the injury is going to go. You see the discoloration, but there's no way of telling till it does evolve where it's going to go. This is one on the heel and then one on the buttocks. And as you can see, the one on the buttocks is the deep maroon color. Now, most of the ones that I've seen on the heels are also that deep maroon color and usually have a very large blister, blood-filled blister on top of them. The stage 1 pressure ulcers, that's intact skin, non-blanchable redness of a localized area, usually over a bony prominence, It may or may not be painful. Again, you have to assess by touching and feeling whether it's firm, soft, warm, or cool. And it may be difficult to detect in darker skinned individuals. And it's just superficial. It does not go any deeper. It can evolve if you don't take care of the problem and offload the pressure. The stage 2 pressure ulcer is a partial thickness with the loss of the dermis, presenting as shallow open ulcer with a red or a pink wound bed without slough. And it may also present as an intact or open ruptured serum-filled blister. And again, I think Diane had this same picture of a stage 2. You will see the edges a lot of times that have the white appearing maceration on them. So you're going to need to offload the pressure. You're going to need to treat the wound, what you see. The stage 3 pressure ulcer is a full thickness tissue loss. Subcutaneous fat may or may not be visible, but bone and tendon or muscle are not exposed. The slough may be present, but it does not obscure the depth of tissue loss. You may have undermining, you may have tunneling. So as you see, the stage 3 goes deeper, but it's not to the level of the bone or the muscle. The stage 4, you're going to have full thickness loss. You're going to have exposed bone, tendon, or muscle. You may have slough or eschar present on some parts of the wound bed, and this kind of wound often has the tunneling and the undermining. And as you can see in this wound over here, you have undermining bone, and you can see the undermining of the skin. And an unstageable ulcer, that's one in which it's a full thickness tissue loss, but the base of the ulcer is completely covered by slough or eschar of the wound bed. And until enough of that slough or eschar is removed so that you can see the wound base and establish the true depth, you cannot stage the wound. And this is a large area of eschar. You know when that opens up, it's probably going to be a stage 4, but at this point you can't determine what the depth of that wound will be. So a pressure ulcer prevention program includes 6 main areas, and that's skin inspection, an assessment of risk, pressure redistribution and offloading, and maintaining skin health, nutrition and hydration, which Diane talked about, that are very important, and patient and family education. We're going to go into some of these deeper, but I heard somebody earlier when Diane was asking what impedes wound healing, and somebody said compliance and patient education. That's a big part of your pressure ulcer prevention. You have to, you can't make them comply, but you have to give them the knowledge so that they can make an informed choice. Avoidable pressure ulcer. An avoidable pressure ulcer is where an individual develops a pressure ulcer and the facility did not do one or more of the following. They did not evaluate the individual's clinical condition or their pressure risk factors. Or they did not define and implement interventions that are consistent with the individual's needs and a goal with recognized standards of practice. They did not monitor and evaluate the impact of the interventions, and they did not revise the interventions as appropriate. So if you have a patient that comes in and they develop a pressure ulcer, and you have not assessed their risk by a tool, either the Braden scale or the Norton scale, some kind of risk assessment tool, and you have not done a well-documented assessment of their skin to say that that ulcer was not present on admission, this is an avoidable pressure ulcer. So you're not going to get reimbursement from Medicare, Medicaid, any of those, for the treatment of this ulcer. And to treat wounds, it's a big business. It is a very expensive proposition in time and money and staff interaction to heal a wound. So it's very important that you have a facility-wide program in place to prevent that. What this means for the nurses is they have to do assessments on a timely fashion, upon admission, it's a daily thing. You have to, if there's a problem, if you have a resident and your CNAs are helping bathe or whatever, and they come to you and they say, would you come look at this? You need to take time to look at it. And if you realize it's a problem with pressure, you need to document it. And then you need to treat it. Unavoidable pressure ulcers, even though you've documented their risk assessment, you've put in place interventions to prevent the ulcer, and you've monitored and evaluated those interventions and know that they're appropriate, and the patient still develops an ulcer, that is an unavoidable ulcer. You see this mainly in palliative care, where a patient comes in, they are nutritionally deficient, their mobility is limited, and even though you've offloaded, their body is just deteriorating. And that's where you see a lot of those. Anybody else have an example of an unavoidable pressure ulcer? I'm not sure they're weight gain. The heel ulcers that I was talking about before, those were avoidable. But in the one case, we had interventions in place. We had documented education that we wanted a mattress to offload the pressure. The patient refused the mattress because the mattress was too noisy. We wanted to put Prevalon boots on. He refused the Prevalon boots because they were too hot. He didn't want them on. And so even though you've provided the education, patient says they understand, but they choose to do something anyway. Was it avoidable? Yes. But not on our part. It was the patient's choice not to use the interventions that we were offering. So skin assessment and inspection. Inspection, this is the most important part. It requires the removal of all clothing and to position the patient for optimal visualization. How many of y'all, when a patient's admitted to your unit, makes them take all their clothes off so you can look at them all over? I think this is where we fail. A lot of times we don't do this. And then all of a sudden, one of your CNAs comes after bathing the patient and says, "Oh, he's got a big red spot on his hip." Did somebody check it when he was admitted? Do we know, was it there on admission or has it developed since then? It involves data collection. You have to look, you have to document location, description of any problems. The assessment comes in when you take all those factors and you've gone over the Braden scale and you've assigned a risk to them, then you synthesize all that information down into a plan so that you can look at, do we need nutritional supplements? Do we need to, maybe for perfusion, do we need some TED hose? Do we need SCDs? Are they diabetic? Do they have sensory loss? When y'all admit patients, do any of y'all, on your diabetic patients, do y'all test their sensory perception in their feet or their lower extremities? Anybody do that? We need to be doing that because as part of the Braden scale, we need to know what their sensory level is. So, in front of y'all, you have the Braden scale. I'm going to go over that in just a minute. There are also the Norton scale, the Waterloo scale. They should be done by an RN. It should occur immediately upon admission. It serves as a baseline for comparisons later. And pressure areas can develop in as little as 1 hour. Do any of y'all work on a post-surgical floor? Anybody get patients from surgery? If you do, one of the things you need to be looking at is when your patient comes from post-anesthesia, you better be checking them when they arrive to see if there are any pressure ulcers. Because a lot of times they've been in surgery for a long time, and even though they've been positioned and have the gel cushions or the gel mats, they could have developed a pressure area while they were in surgery. So you need to look, you need to inspect, you need to disrobe them, and that's part of our job as nurses.
I have a question. Would that be for any, maybe like a young guy in his 20s and he's fit and all that? Would he be at risk too? Because
Sure he
he's
would.
been in surgery for so long?
Sure he would. If you're under anesthesia, you're under stress, and you've been laying in a position, especially if it's a long surgery. So yes, you should be inspecting. When they come to your unit, especially if they've been to surgery or they've been in the ER even for a long time, you need to inspect and assess. Okay, my slide for the Braden scale didn't come out too well, so I had Sue print off a better copy for you. We're going to go over what the different areas mean. Sensory perception refers to the patient's ability to respond meaningfully to pressure-related discomfort. That means if they're uncomfortable, can they move themselves? Can they reposition themselves? Do they have the ability to respond to that that pressure-related discomfort? And sometimes they may not even have, they might not have a as intense response to the discomfort that a normal person would. And it's dependent upon their degree to be able to feel and to communicate that discomfort. Like I said, you need to check their level of sensory ability, especially in their lower extremities, especially on our diabetics. I think probably 80% of our patients are diabetic, and I think maybe 1 out of 10 is even moderately well controlled. So you know that it's affecting their sensory perception in their lower extremities. Moisture. Moisture is not just incontinence. It increases the skin's vulnerability to the different forces, the shear, the friction. Do you have a patient that is diaphoretic quite a bit? We have several that they sweat all the time. We do a linen change at least once a shift because they have diaphoresis that much. And the other thing is they may have a draining wound. And even though you're doing the right dressings and everything, sometimes the wound exudate is not well contained. And when it's not well contained, it can cause the skin to become macerated and have vulnerability to moisture damage. Activity is a matter of degree. You need to pay close attention to the subscales. Even a little bit of increased activity, the patient being able to get out of the bed to the chair, even if it's just for short periods, it equals a decreased risk. I know a lot on our long-term care units, patients will say they don't want to get out of bed. You need to try to encourage them to get out of bed at least for meals. You know, just that movement of getting up out of the bed and moving to a chair decreases their risk on a daily basis. And mobility. That refers to the patient's ability to change and control their body position. It does not refer to their ability to ambulate. A lot of people confuse that when they're looking at the Braden scale. We have some people that are not ambulatory, but they can move themselves in bed. They can turn themselves in bed. We have others that can't turn. So you need to establish a turning schedule for those people that are increased risk because of their mobility limitations. And nutrition, that refers to the person's usual food intake. Do they eat well? Do they eat 50% or do they eat do they eat 100% at breakfast and then don't eat for the rest of the day? We have some of them that do that. You also need to look at their lab work. Does their albumin or the pre-albumin indicate a malnourished status? If their lab work indicates that they're malnourished, then they're going to score lower on that and be at a higher risk. And you want to, at that point, get your dietitian involved. You want to work with this patient to find out their food preferences. As Diane talked about earlier, you would want to see if supplements are in order to help prevent, because they're at a higher risk. If they don't have any wound problems now, but they're at a higher risk, you want to do everything you can to prevent that. Friction and shear. It occurs when skin rubs against the surface. And shear is when friction and gravity come together. You know, we slide people up in bed all the time when we should be lifting and moving them up. Dragging them doesn't reduce friction or shear. We have new aids to help us when we're, the SAGE model, I don't know if y'all have seen it, where it's a lift sheet as well as an incontinence pad. Works very well to reduce the friction and shear. What's another way we reduce friction and shear? What's that?
The position of the bed.
And where should the position of the bed be? 30 degrees or less. More than 30 degrees, it puts a lot of friction and shear on their bottom. Maintaining skin health. We want to have interventions that are minimize that minimize the threats to the skin integrity. Those things are like the pad, the lift pads, the slide boards. We don't want to use alkaline soaps because that destroys the normal pH of the skin, and it reduces the skin's ability to act as a barrier. You don't want to scrub your patients. You know, I know that sometimes we have patients that come in from home that need scrubbing very badly, but you don't want to do that. You want to be gentle with the skin. You want to use a moisturizer or an emollient to prevent cirrhosis. That's dry skin. How many of you have seen patients come in and their feet and lower legs are just dry, thick plaques of skin? What works well to get rid of that? Does anybody know? Two of the cheapest things after you cleanse it is you either use Vaseline or you use A&D ointment. And within a week you'll see a huge difference in the way their skin looks. You want to make sure your patients are getting enough fluid You don't want them dehydrated. What do you look at in a patient to see if their fluid intake is probably good? The turgor. What else would you look at? Exactly. Exactly. So, what are some ways that we can make sure that our patients are well hydrated?
Encourage fluid intake, IVs.
Yeah. IVs are good, but you know, just on a daily basis, a lot of our patients won't even reach for the cup, but if you hand them a cup, they'll down the whole thing. So it's just as small act as pouring them a cup of water and saying, here, would you like something to drink? And most of the times, huh?
If you ask them, maybe they have dental problems and don't want cold water, or they don't want cold fluids for.
Exactly. Most of our patients can tell us that whether they want their water pitcher at bedside with ice or without it, but we still have a lot of patients that are demented and they won't think to take a drink. And it's our responsibility as nurses to look at this and check them and make sure that they're taking. I'm not saying keep eye nose on them because, you know, that's not always indicated, but just the simple act of getting them to drink enough fluids. If they're incontinent, you want to use a moisture barrier or ointment. What kind of barriers would you use? Can you think of? Yeah, that's one. What's another one? Zinc. When you move, use lift sheets or lifts or the hover mats to avoid shear. How many of y'all have hover mats or hover jacks on your unit? Anybody familiar with those? Yeah. A lot of times, if you're sending an immobile patient down to x-ray and they have to go by gurney, I know at our facility we have the hover mats. And it's a very nice thing to put them on that, and it's a very nice transfer for them, and it doesn't interfere with their x-rays. Okay. Nutritional deficiencies equal decreased muscle mass and less padding over bony prominences. So when they have less muscle mass, they're going to break down quicker. You see these little men and women that come in that they don't even have a place to give a sub-Q injection because they're so thin. That makes them at higher risk. They're twice as likely to develop skin breakdown. I would say even more than that. I would say it's a greater chance. So, as we mentioned earlier, you want to monitor their food and their fluid intake and make sure you assist with them. If you notice that they're not eating well, or if their tray comes back and they're not eating hardly anything, you need to investigate why. You need to ask them, you know, what's the problem? Are you not hungry? You know, you need to find out the reasonings, because like you said, it may be a dental problem. It may be something that we can help, but we need to know what the problem is. And it just takes a few minutes extra to find those things out. And you want to do a nutritional consult when they're compromised at all. You want to make sure that you get a dietitian to come up and talk to them, because that way the dietitian can address their food preferences and custom design a plan that will help them. The other part of a problem or the preventative measures is a pressure redistribution and offloading of pressure. That's accomplished with different support surfaces. When you have a patient that qualifies, you can get specialty surface mattresses that will, like low air loss mattresses, those type of things that will offload the pressure. You need to turn and reposition. You know, we used to say every 2 hours. but you need to establish a turning schedule. And if they're more prone to breakdown, the higher risk they are, the lower their Braden scale, you want to turn them every hour. I know that it says every 2 to 4 hours, but when they're in a chair, how do you reposition them? Does anybody know? Sometimes you can just tell them to move, you know. Just ask them to wiggle their hips. It's just, but you want to make sure you have a support surface in a chair. If a patient is confined to a wheelchair, they need a support surface in that wheelchair. Repositioning techniques. You're going to turn them, but is there anything to remember when you're turning a patient from side to side? Odd and even hours. What else? How far do you turn them? Right. You limit the head of the bed elevation. Can anybody tell me why we do that? We talked about it a while ago. Right.
What if there's COPD though? Then you gotta decide which one.
You got to decide which is more important at the time.
Yeah.
But you're still going to, even if there's COPD, you can limit the time that they're up more than 30 degrees. You know.
And trach care patients.
Yeah. You know, we feed patients in bed sometimes. They're going to be up, but you still need to lower them after, you know, reasonable time after they've had their meal to less than 30 degrees. You want to transfer without lateral shear. That means you don't drag, you lift. Or you use a slide sheet that doesn't cause friction. Floating of heels. How do we float heels? Anybody know? Pillows are good. In the VA system, what else do we have? Prevalon boots. All right. And seating. A lot of times when you go in a unit and you see people in wheelchairs or in the Geri chairs, how do you see them seated? How is their posture? A lot of them are slumped forward and they're putting pressure on the coccyx. That's why I'm saying when they're up in a chair and they're at risk, you need to have a support surface like a Roho cushion, even an egg crate cushion, although I'm not real fond of egg crate cushions because they don't last very long. But that's better than nothing. Diane talked about pain. It does have a big effect on wound healing. And as part of your pressure ulcer prevention and assessment, you have to assess their pain. It affects their physical, psychological, and spiritual well-being. A lot of times, if a person is in pain, they don't sleep, they don't eat, they become anxious or very irritable. It limits their mobility. It limits their ability to change positions. You know, we want to relieve their pain. Pain causes stress. Stress releases cortisol. Cortisol impedes wound healing. It also makes you more prone to skin breaking. So you want to reduce the pain at all times, but then what about pain for dressing changes? Especially if you're going to do debridement. You need to think about what you can do to reduce the pain. And if you manage the pain, it enhances wound healing at a cellular level. Just because of the chemicals that are dumped into your body when you're in pain, they impede the wound healing. So if you can relieve the pain, then you have a better chance of wound healing. Patient and family education. It must be at an appropriate reading level. Does anybody know what the optimal reading level is for the majority of patients?
Fifth grade.
Yeah. Between 4th and 5th grade. the teaching you give them, it must be consistent with their goals and their needs. You know, their goal may be, I just want to get out of here. You have to say, well, you know, if you want to get out of here, here are some of the things we need to do along the way. And you have to make sure they understand what you're telling them. You have to get them to repeat back to you or demonstrate a knowledge of what you've been teaching. And you must document that you've taught them, because that's part of your pressure ulcer prevention. If they come in here and a patient's developed an ulcer and they ask you, what did you teach this patient about prevention? Would you know? Would it be in the chart? Because I know that as nurses we're busy, and I know we're always providing education, but do we always take time to put it in the chart? And that's something we need to do. It's a really important part of the prevention program, and that you have documented, and you've documented the response to your teaching, whatever that may be. Okay, when you're documenting, you must document it. They recommend as a pressure ulcer prevention program that you document in the medical record in a specific location. So would you know where to look in the chart to look for the assessment, like the initial assessment on a patient? For those of you in the VA system, where would you look in the chart to find out their initial assessment for skin?
The band.
Exactly. You have to, the skin assessment is the assessment includes all the combination of your inspection and your nutritional, you know, your risk analysis, everything. Your documentation has to include the assessments, has to include the interventions, has to include, does this patient need a pressure prevention? Now, some of our patients on the Braden scale, we say they don't need a prevention program because they're at no risk or low risk. How often do we update that assessment and that risk level? I think it depends on what type of unit you're on. I think most of the long-term care units, it's weekly for the first 4 weeks and then monthly. But you can do it more often. There's no regulation that says you can't do it more often. And if there's a change, you need to do it. You have to document skincare. What skincare are you providing? You know, that doesn't just include wound care. That includes, are you providing lotions for dry skin? Are you using a barrier cream? Because this patient has a problem with incontinence. And then if they do have a pressure ulcer, how are you managing that? What kind of treatment are you providing for that? And we'll talk about this later in the morning, but use uniform descriptors. Diane referred to saying egg-shaped, or, you know, it was the size of a grapefruit, that type of thing. We need to all be on the same page using measurements, metric measurements. If it's oval, if it's round, if it's square, if it's an irregular shape, whatever. And when you provide wound care, or you decide not to provide wound care that day for some reason, you need to document it. Because how does the next day's nurse know that that wound care was done? How does he or she know what you did? And also, they want you to measure pressure ulcers at a set frequency per facility policy. Here we measure weekly. We can measure out more often, and sometimes we do measure more often. Now, what is the purpose of measuring? What? So that way you know if you have a stalled wound or if it's worsening. And if it's worsening or stalled, what do you need to do? You've got to change your interventions. And we talked about photography. So far, I don't think our facility allows us to photograph. I kind of wish they would. I think it would give everybody, even though we can all describe it, it's like the three men that were blindfolded and describing the elephant. You know, one described the head, one described the tail, one described the ears. It was nothing like the other one. If you can see it, you know, in addition to the descriptors, it's consistent across the board. And you need to provide accurate and effective handoff communication. Can anybody tell me what that means? What if you're getting a patient in from somewhere, and from another VA facility, and you've read the VANOD and it says they have a stage 2, and you're getting a report and you ask, any skin breakdown? No skin breakdown. And you see their last assessment. It was done 2 days ago. It says they have a stage 2, but yet they arrive and there's nothing. You can't find the ulcer they're talking about. Or conversely, you know, they say, yeah, they have a stage 2, and they get here, you know. I mean, they tell you in report there's a stage 2 because they read it in the chart, but when they get here, you can't find it. That's why it's so important that when you admit a patient or a patient comes to you, that you do an inspection on admission so you know what was present on admission to your unit. Not what some other nurse documented. You need to document exactly what was there when you go. And by the same token, if you're sending a patient to an appointment somewhere and they have a wound, you might want to make sure you communicate that to the clinic you're sending the patient to. You know, and you document that you've communicated that to whoever. The wound assessment, you're going to include the anatomical location. That's what we're saying about using descriptors. You need, is it lateral, is it medial, is it coccygeal, is it sacral? You know, is it a trochanter, is it an ischium? You have to use those terms when you're documenting. And then, you know, you need to, the extent of the tissue involvement. Is it full thickness? Is it partial thickness? If it's a pressure ulcer, what stage is it at? Or what stage, you know, is it a stage 3 that is healing? You know, you don't say, well, it was a stage 3 and today it's a stage 2. You don't reverse stage. You want to describe what the wound base looks like. Is it granulized? Is there eschar? Is there slough? What color is it? And you can express that in percentages. Like if 30% of the wound is yellow slough, then you need to document that. And like Diane was saying, on a head to toe basis, you can use a clock face and say at 3 o'clock, there's between 1 and 3, there's about 30%. And then the tissue color, the peri-wound condition. We've talked about the macerated edges, the rolled edges. You know, is there redness? Is there bruising? What is it? The wound measurement and shape. Any exudate. You want a description of the exudate. Is it sanguinous, serosanguinous? Is it creamy? Is it purulent? Is it green? And any odor. You may not can describe the odor, but if there's odor present, you can say malodor. I mean, most of us in here as nurses, we know different smells. I know the one smell I can identify right off the bat is Pseudomonas. You just look at the color and you get that smell and you know what it is. When you're measuring the wound size, you're going to measure the length at the point of the greatest length, head to toe, and the width is side to side. The depth, it's most commonly done, as Diane said, by placing a cotton tip swab and then measuring that. Tunneling and undermining is also measured with a swab, and the location is documented like it is a clock face, with 12 o'clock being the head of the patient and 6 o'clock being their feet. The push tool, and that's a pressure ulcer staging healing tool. It was developed by the National Pressure Ulcer Advisory Panel to monitor change in pressure ulcers over time. And I'm sorry I didn't have Sue print that, but it's a week-to-week document that you document the size. It's a measurement of the size of the wound, the exudate, the wound bed, and those three things are rated, and you obtain a score, and then you plot it on a graph to show improvement or worsening over time. That's part of your pressure ulcer prevention program in the hospital. Not all ulcers are pressure ulcers. You have to assess the wound to make sure it really is a pressure ulcer. Is it over a bony prominence? Was it caused by a medical device? Or is it a diabetic foot ulcer? Not all ulcers are pressure ulcers. Pressure ulcers, for the most part, are preventable, but you have to make sure that you have prevention measures in place and that you follow those prevention measures. You have to accurately document. One of the things that we're trying to do on the unit I work on, and I think throughout this facility, is that at least 2 RNs weekly lay eyes on the wound, and we both agree on what the wound is, where it is, and the measurements. And we both sign the note. That way, there is consistency. Now, is that realistic? Because sometimes we don't have 2 RNs to do that. So we can't always do it, but we are trying. In pain control, you need to really be assessing your patient's level of pain. And is that pain coming from the wound? Is it worsening pain? Is it changed? Do you notice, if you're the one that's consistently doing the wound care and you've been doing the wound care and this patient has never complained of pain, and all of a sudden you see him jumping and flinching when you're doing wound care, you know something's changed. And you need to investigate that and find out what's going on. Pressure ulcer prevention is a team effort. Not just one person can do it. You have to involve your team. And the team includes the providers, the physicians, the nurse practitioners. It includes the RNs, it includes the LVNs, it includes the CNAs. And you've got to make sure that you communicate with them that their input is important and that you want to know what's going on. If they see something that you haven't seen, you want them to be able to come and tell you. The elements of a successful pressure ulcer prevention program include skin inspection on a daily basis, because things can change on a daily basis. You want to do a risk assessment. And as I said, you want to do that anytime things change. You want to do it at least on a weekly basis on the long-term care unit for the first 4 weeks, and then monthly thereafter. On acute units, I think the policy is you do it daily or every other day. I'm not sure which. You want to make sure that if they have a problem with pressure, that you have, if they need a support surface, that you've got the ball rolling to get the specialty bed or whatever. Or that you're offloading, like with Prevalon boots, you're offloading their heels. Our diabetics, podiatry works real well with us here about getting rook boots to offload pressure on people's feet. you want to maintain the skin health. That means, if your patient hasn't bathed in a week and they really don't want to bathe, yes, they have the right to refuse, but you sometimes have to do what you can to talk them into it. You need to assess their nutrition and hydration. You need to remember that sometimes it's just as simple as, would you just like a drink of water, Mr. Smith, and pouring him a cup of water and handing it to him. And then patient and family education. They need to know what causes pressure ulcers. They need to know they need to either be, if they're able, to be up out of the bed and moving, not just lay around. They need to know that if they can move, they should be repositioning themselves. If they can't move, we need to be in there repositioning. And the family needs to be involved in that as well. Has anybody got any questions before we take a short break? Yes, ma'am.
I have a question about the grading scale under the activity column. I work in ICU, and most of our patients in the world are ambulatory, but we force them on bed rest
Right.
because they have equipment and they're hooked up to a monitor. And so I have always been confused with that column, what to rate them.
Diane, can I
Yes.
borrow your brain scale for a minute? Okay. I would rate them for the time that they're in there as bedfast. Because that truly is, you're not going to let them get up and walk, because if they're in ICU, a lot of times they're, like you said, they're either intubated, they're hooked to various machines. So for that time period, they're bedfast, but then when they become, they go down to like the PCU or to the floor, then that assessment would change and their risk factors would change.
Okay, thank you.
You're
Then I have one other question.
Okay.
Could you differentiate between coccyx and sacral area?
I'm going to let Diane help me with this one, because this is a bone of contention among some of the nurses I work with too.
Absolutely. I think it's tricky, and I wish that we had actually developed an anatomical chart that we are trying to incorporate as part of our documentation so the nurses are consistent with what they're talking about. Probably the best way to think about it is coccyx. If you think about where the crack stops, that's your coccyx. Sacrum is the area surrounding that. Probably the best way I can think of to describe that. So the coccyx is actually sort of centered within the larger sacral area. But think about coccyx, if you're really talking about the tailbone, it's where the crack stops. And then sacrum is the area around it, above that area.
Have you seen the leave-in dressings that are the one for the coccyx? Okay, the sacrum is, like she's saying, the big area, and then the little, where it almost looks like a tailbone at the end, that's the coccyx.
But yeah, and it's hard because I think a lot of clinicians will use those words interchangeably. And, you can have a coccygeal wound, but sometimes folks will also call that a sacral. So, yeah, I think the big thing is, and especially too, I think one of the things that Sheree made a big point about that was really important is when you're assessing it, especially for the initial assessment, have a couple of clinicians look at it at the same time and then agree, okay, well, this looks like it's the sacral area, so let's document it as the sacral, or this is a right ischial. We agree that this is right ischial, so we're going to call it this. So maybe, even kind of confirming that with another clinician can be really helpful, so that way you have consistency.
How many of y'all are from the VA system? Okay, the majority of y'all. I know that, like Diane said, we're working on a pocket chart that's laminated that it's marked with anatomical locations, it's marked with the descriptors, and hopefully that'll be out sometime soon
Hopefully.
for everybody to have.
That'll be
We have a question right here.
Okay.
It's a hard copy.
The question I have is that earlier in your discussion, you stated that Medicare will not reimburse for unavoidable pressure ulcers that are attending during hospitalization. But what about if it should be an unavoidable pressure ulcer, but caused by the patient's non-compliance? Is it still non-reimbursable at that point?
They won't pay for avoidable pressure ulcers, is my understanding.
The avoidable.
Yeah, the avoidable. And it's just like The other big thing right now, I'm sure all of you, is urinary tract infections from Foley's. That is a situation where they're limiting reimbursement because it occurred because of our care or lack of care or whatever.
But provided we do all of the care and all of the documentation, and we still have that pressure ulcer because the patient refused to offload. So does Medicare refuse payment?
I would think that would be one that I really don't know the answer to that question, but I think that's one that you could fight but you would have to have your documentation. You would have to say, this is what we taught the patient, this is our recommendations, this is how the patient responded to those recommendations and is refusing these things.
Many of our patients that will go down and smoke
Exactly.
instead of being on that bed and offloading that heel ulcer. So do you address that in your chart?
I think you should. I think you very well should, because as a nurse, you're going to be documenting your teaching that you're going to teach them that smoking interferes with their wound healing and it interferes with their circulation. So this is what I'm saying. It's very important to document that. Document what you, and most of the time you can get, the doctor will say, we have offered them, the nicotine patches, or we've offered them whatever, smoking cessation classes, and they choose not to do that. And that is their choice. They have rights as an individual. We can't force these treatments upon them if it's not something they want.
That's the whole non-compliance issue it's a huge challenge, I think, for us as healthcare providers. And I think every time that you make an effort to educate, it's always critical to document every single episode where you've made that effort to educate them or to advise them or to counsel them. Document what you taught, document their response. That will help cover. In response to, what you were asking about with the issue of the hospital acquired, yeah, that was a huge issue that came out in 2008. There are a series of what CMS calls never events. They're basically hospital-acquired conditions for which CMS is saying, no, we're not going to pay you because we think that you could have prevented it. Catheter-associated urinary tract infections is one. Another one, of course, are stage 3 or greater pressure ulcers. The thing that has become a real issue is it does help in your defense, and also from a litigation perspective as well. It helps in your defense if you have documentation that supports that you made efforts to address that noncompliance. I don't know what the final rulings are for CMS when there are issues of noncompliance, but I do know that from a litigation perspective, in doing med mal cases, it is very defensible if you have documentation that supports that the patient was not compliant.
But I think that's where we fail a lot of times
We
in our
don't document.
documentation. We don't take credit for the education we provided, and we don't document the response. And that's a very important part of the plan. Anybody else? Okay, we're going to take about a 10-minute break, and then we'll go to the next one.
Would have given you all of my heart, but there's someone who has torn it apart, and she's taken just all that I have. If you wanna try to love again, well baby, I'll try to love again, but I know the first cut is the deepest. Well baby, I know the first cut is the deepest.